Inherited retinal diseases did not have a treatment, but this is likely to change with the introduction of new innovative treatments. We saw recently the arrival on the market of Luxturna, and there are many other therapies under development in many parts of the world, including India, as we have discovered today. In this perspective, it is visual function evaluation plays an important part for the precise identification of the disease, for the evaluation of the efficacy of the treatment, and for the evaluation of absence of side effects. I took the slides from Professor Bart Leroy from Ghent, just to show that there is a wide spectrum of different disease with the involvement of different genes, of course, but also what I want to point out with an onset in life at different ages, affecting different regions of the retina and affecting either day or night vision. So we need, for these different diseases, different techniques, for example, to assess young children or to assess local defects of the retina. Vision electrophysiology, of course, plays an important part in the evaluation of visual functions, but it has some important limitations. For flash electroretinography, as you can see here, we are not able to detect the early stage of diseases that affect only a small local part of the retina. And also another limit is at the well-advanced stage, it is well possible that the ERG response is extinguished, whereas we may be able to get responses with some other techniques. Multifocal electroretinography, as was shown yesterday, it is only stimulating the central retina, and also it is limited to the examination of the photopic system, and it does require prolonged stable fixation. So all these tests are important, but have limitations. This is why, in my opinion, electrophysiology is only part of the approach we can have in terms of function evaluation. And at Metrovision, what we have done is integrate on the same device the different tests. As you can see here, we have integrated standard automated perimetry, not a big deal, you will say, but also Goldman manual perimetry, a number of tests to evaluate rod function, including FST, dark adapted chromatic perimetry, and dark adaptometry, pupillometry that can be useful for testing non-cooperative patients, and also eye movements. And because my time is limited, I will only present two of these. So first, full field stimulus threshold, or FST. It's a test done after dark adaptation and based on the psychophysical threshold of perception of Ganzfeld flashes similar to the one we use in electroretinography, and we use a staircase thresholding techniques similar to what is used in perimetry. This is available on our different systems, and we can do it with either white flashes, but also it can be of interest to do it with blue and red flashes, as I will see later. This is a slide from the group in Shea Hospital, Philadelphia. So we actually in this test, we use red and blue light. And for these wavelengths, the cones are equally sensitive to blue and to red light, whereas the rows are much more sensitive. So if we do a test on a normal subject, we will get a huge difference between the response to the red and to the blue, provided we have good rows. Typically, a 25 decibel difference will demonstrate that the response is mediated by rows. This test has a number of advantages. It is more sensitive than ERG. It is independent of fixation, so we can test patients with nystagmus. And it is quite fast, because after dark adaptation, within 2 minutes, we can get a good response for blue and red stimulations. So we can include it in the ERG protocol as an additional test. It has, of course, limits. It needs patient's cooperation, And also, it does not provide information on localization. So actually, it's not like ERG that gets the sum of all the response of the retina. It's actually picking the best, the most sensitive area of the retina. So you could very well have evolution of the disease in the periphery and not detect it. So this is where the dark adapted chromatic perimetry comes into play. So the MonCvONE can be used as a Ganzfeld stimulator, but also as a projection parameter. And it has a great advantage to have a very wide range of luminance, more than 90 decibels. So because of that, it can not only operate in the photopic range, but also down to the scotopic range. And we will have the possibility to do static dark adapted perimetry with blue stimulus, as you can see here on the normal subject, with red stimulus. And it's the same type of reasoning we had before. The cones have similar response for both wavelengths, and the rods are much more sensitive. So if we make a difference between these two, this is a map of the difference between the two previous maps. If we look at local thresholds, if the difference is larger than 23 decibels, we know the response is mediated by rods. If it's less than 7 decibels, it's mediated by cones, and in between, it's a mixed response. Of course, testing 75 points, as you see here, takes a lot of time, but you can have reduce the number of points for a specific area, or eventually you can also use manual Goldman perimetry with scotopic and red and blue stimuli, in which case it can be useful, for example, for testing non-cooperative patients. And it's much faster also when you are dealing with large deficits. Just a few words about our eye tracking technology. All our device has this as an option where we analyze the image of the eye in real time and measure the fixation based on the position of the pupil relative to the cornea, so the corneal reflex. And this is a typical report that we produce at the end of an exam. This is indicating the stability of fixation based on the BCEA, the area in square degrees of fixation. We can also have information about pupil size and about blinks. It is also important, eventually, as an endpoint in a clinical trial to evaluate the stability of fixation. It is available on our different exams, of course, electrophysiology, multifocal ERG, pattern VP, also in automatic perimetry, manual Goldman perimetry, and dark adapted chromatic perimetry. And I'm just showing here an example of a patient where Goldman perimetry was done. And we can see on the eye movement report that the fixation was shifted down by something like 15 degrees. And this allows the interpretation of this visual field, demonstrating that there was a central defect which made the patient fixate on the side of the scotoma. So the question was, why should you buy my product? So because it includes on the same platform different tests. That means one single instrument instead of several. You save space. You eventually save money because it's cheaper to buy one, but instead of several. Also, the advantage is that it means less need for training for the technician, only one software, one interface. Also, it's saving time for the patient who doesn't have to wait for the next technician to be available to run maybe 3 exams. So I hope that all of you are convinced that combination of vision electrophysiology with vision psychophysics can be of interest, and I thank you for your attention.